Welcome to the Hospital Medicine Unplugged podcast. Today we're undertaking a deep dive into rhabdomyolysis, that critical syndrome. It can range from just an asymptomatic creatine kinase elevation all the way to acute, life-threatening organ failure, primarily acute kidney injury, or AKI. Our audience today is you, our colleagues, fellow hospital physicians, and our mission is pretty precise. We need to cut through the noise, really, and quickly distill the latest evidence and consensus recommendations. We want to focus on early diagnosis and the critical management of rhabdomyolysis, specifically aiming to prevent those severe sequelae, the really feared outcomes in our hospitalized patients.
It really is a foundational topic for hospital medicine, mostly because rhabdomyolysis is, well, it's often missed or can be quite insidious in its presentation. Yet it absolutely demands immediate high-intensity intervention. As we know, this is a cascade that starts small and then just accelerates quickly toward multi-system organ failure. We really have to be several steps ahead of the curve on this one.
Okay, let's unpack this syndrome then, starting right at the cellular level. When we talk about myocyte breakdown, what exactly is the critical destructive mechanism, the thing that initiates the systemic crisis?
Right. Rhabdomyolysis is fundamentally defined as the rapid breakdown of striated muscle fibers, and that leads to this massive release of intracellular contents. The core mechanism is basically a loss of cellular integrity. It's driven by myocyte membrane injury and severe adenosine triphosphate, or ATP, depletion. When the cell effectively runs out of ATP, its energy source, it just loses the ability to maintain normal ion gradients across the membrane.
And that loss of gradient, that quickly leads to a fatal flaw in the cell's internal regulation, specifically involving calcium, I believe.
Exactly. The failure to pump calcium out or even sequester, it leads to a sustained pathological increase in intracellular calcium concentration. That calcium overload then acts as the primary signal. It activates destructive enzymatic pathways, and think proteases and phospholipases that essentially trigger autolysis. They digest the cell components from the inside out. And this culminates in myocyte necrosis and then subsequent rupture.
Okay, so when that cell ruptures, that's when this truly dangerous cocktail floods into the systemic circulation. What are the key products we're worried about? The ones turning local muscle injury into a systemic problem.
Clinically, the most dangerous product is myoglobin. That's the major nephrotoxin we track. But we also see these massive releases of creatine kinase, or CK, potassium, phosphate, and uric acid. The concentrations of these substances can reach toxic levels pretty quickly, causing immediate electrolyte derangements and, critically, that kidney damage we mentioned.
Let's focus intensely on the myoglobin then, because that's the direct link to acute kidney injury. For our colleagues listening, detailing the mechanism of rhabdomyolysis-induced AKI, or RIAKI, really helps underscore the urgency of fluid intervention. So how does myoglobin actually transition from just a muscle protein to a kidney killer?
Yeah, myoglobin is toxic through basically a trifecta of pathways. They all contribute to renal failure. First, it causes direct cytotoxicity to the renal tubular cells. It triggers cell death and inflammation right there. Second, myoglobin precipitates within the renal tubules. This happens especially in the setting of aciduria and volume depletion, leading to the formation of obstructive casts. They physically block filtration. And third, and this one is often underappreciated, myoglobin acts as a potent mediator of renal vasoconstriction, which directly reduces renal blood flow.
And when you layer on the systemic effects of the rhabdo itself, which often includes profound hypovolemia because fluid is sequestering in the damaged muscle, the kidney is already sort of primed for failure.
Precisely. Systemic hypovolemia compounds the issue by reducing glomerular perfusion pressure. So this environment, you've got low flow, vasoconstriction, and highly acidic urine. It creates the perfect storm that can rapidly progress from just tubular damage to full-blown AKI.
That paints a necessary picture of the pathophysiology. Now, moving to the bedside, our biggest challenge as hospitalists is often just identification, right? We have to maintain an incredibly high index of suspicion, especially since the classic presentation is actually the exception, not the rule.
That's the critical point, absolutely. We're all trained to look for that classic triad: myalgias, muscle weakness, and dark urine. But studies consistently show this triad is only present in a minority of cases, maybe 10%, perhaps 20% at best, and up to 50% of patients lack overt muscle complaints entirely. Or they present with incredibly nonspecific symptoms, generalized malaise, nausea, maybe altered mental status, particularly in elderly or sedated patients.
So we really need to rely heavily on laboratory confirmation and risk stratification then. How do we establish the diagnosis definitively? And what are the specific thresholds that should trigger an immediate aggressive management protocol?
Diagnosis is established by serum CK levels exceeding 5 times the upper limit of normal. That's the baseline definition. However, to stratify severity, specific thresholds are commonly cited in the literature. We generally use greater than 10,000 units per liter for exertional rhabdomyolysis, and often greater than 5,000 units per liter for non-exertional causes, as the trigger point for, let's say, severe management protocols. Remember, the absolute CK number is important, but maybe more importantly, its trend dictates the level of urgency.
Okay. And beyond CK, what's essential for our immediate initial lab evaluation? We need to capture the whole picture, the full extent of the chemical fallout.
An immediate comprehensive panel is really non-negotiable. This includes CK, LDH, and AST. Those are the muscle enzymes. Critically, we need renal function markers, BUN, and creatinine to establish a baseline. And given the immediate threat, full electrolytes are absolutely essential: potassium, phosphate, calcium. We should probably also check uric acid, as hyperuricemia can contribute to tubular obstruction, though it's often, overshadowed by myoglobin in terms of immediate danger.
Yeah, for our expert audience, the use of clinical scoring tools has become, well, much more refined in risk stratification lately. We probably need to move beyond just looking at the absolute CK level. Let's talk about the McMahon score. What specific parameters should we focus on when utilizing this tool for risk stratification?
The McMahon score is an excellent tool, mostly because it moves beyond just a single CK number and incorporates key clinical risk factors. It assesses parameters like age, gender, the maximum CK level reached, the etiology of the rhabdo, for instance. Trauma scores higher. And crucially, it includes the admission creatinine level. This allows us to better predict the patient's risk of developing AKI, which is usually defined as needing renal replacement therapy or even death.
Okay, so for example, if we have, say, a 70-year-old patient, maybe with some baseline renal insufficiency, admitted for sepsis and prolonged immobilization, and their CK is, 15,000 units per liter, that profile immediately suggests a high McMahon score. How should a score in that higher range practically alter our management plan right from the start?
A high score, typically defined as greater than 6 or 7, is basically a flashing red light. It absolutely necessitates aggressive management from the outset and often mandates an escalation of care. I mean, this patient should likely be managed in a monitored setting like the ICU or maybe a high acuity step-down unit rather than the general floor. It forces us to be more aggressive with fluid titration and certainly more vigilant about impending hyperkalemia. It sort of refines the evidence supporting the need for immediate maximal intervention.
Right, it helps justify that higher level of care. Okay, before moving to treatment, let's deeply survey the causes. In hospitalized patients, rhabdo is almost never due to just one single factor. It's usually multifactorial. Let's expand a bit on the drug culprits, as polypharmacy is just so common in our patient cohort.
Oh, drug-induced rhabdomyolysis is a vast category. We certainly see the usual suspects: antipsychotics, especially high doses of atypicals, SSRIs, lithium, and colchicine. But for our specific population, the statins remain probably the most clinically significant, despite the rarity of true rhabdomyolysis. It's about 1.5 cases per 100,000 patient year, something like that. The real danger often isn't the statin alone, it's the drug-drug interaction.
Like combining statins with potent CYP3A4 inhibitors. That's a classic interaction.
Exactly. When you combine a statin metabolized via CYP3A4, like simvastatin or atorvastatin, with certain macrolide antibiotics, think clarithromycin or erythromycin or azole antifungals or even protease inhibitors, you dramatically increase the concentration of the statin, which just skyrockets the risk of myotoxicity. Identifying these high-risk combinations upon admission is absolutely essential for prevention.
Good point. And we can't overlook the physical factors either, particularly prolonged immobilization, maybe in the setting of altered mental status or deep sedation. That's a surprisingly common hospital trigger, isn't it?
It really is. It's a hospital-acquired trigger we have to be vigilant about. Prolonged static pressure, particularly after surgery or following falls or in patients requiring restraints, sometimes combined with high-dose atypical antipsychotics for behavioral agitation, this leads to ischemic injury to the muscle tissue. The muscle is essentially crushed internally by the patient's own weight. This is a common pitfall we encounter, especially in the critical care setting.
Okay. And finally, infections. We know sepsis can be a trigger, but certain viral causes have emerged as particularly important in recent years.
Yes, sepsis and severe viral illnesses, influenza, HIV, are major factors. They often combine direct myotoxicity with systemic hypoperfusion. And yes, as an emerging cause, COVID-19 frequently presents with rhabdomyolysis. Sometimes it seems disproportionate to the severity of the respiratory illness itself, and it can lead to rapid RIAK. We also have to remember underlying metabolic derangements like severe hypo or hyperthyroidism or diabetic ketoacidosis. They must also be excluded as contributing factors. Identifying and, importantly, halting the causative agent or agents is, of course, step 0 in management.
That provides the essential foundation. Now let's transition immediately to the management phase. Let's focus on the critical intervention that truly determines outcome: fluid resuscitation.
Right. This cannot be overstated for you, the listener. Early, aggressive intravenous volume expansion is the single most important intervention in managing rhabdomyolysis and preventing AKI. It is the absolute cornerstone of therapy. What we're trying to achieve is a high-flow diuresis strategy to rapidly dilute and flush the myoglobin before it can wreak havoc in the tubules.
And the evidence seems absolutely clear that timing is everything here. We're talking about a critical intervention window.
Precisely. Fluid initiation is critically time-sensitive. The goal is to start fluids ideally within the first 6 hours of muscle injury, if at all possible. Delayed resuscitation is strongly associated with a dramatically increased risk of developing AKI, which, as we said, drastically worsens the prognosis. The clock really starts ticking the moment the injury occurs or the patient loses consciousness.
So we need high volume, high urgency. What is the clinical goal in terms of volume? Or maybe more practically in terms of urine output for the first 24 hours?
The clinical goal is high urine output. Specifically, we aim to maintain 300 milliliters per hour, and we maintain that target for at least the first 24 hours, often longer, until the CK levels begin to trend downward aggressively. For our colleagues, this means recognizing that in severe rhabdomyolysis, the daily fluid requirements can easily exceed 12 liters. You have to think of it as a massive ongoing intravascular fluid deficit that you are actively trying to outpace.
Okay, 12 liters or more. That brings us to the perennial debate in the literature, the choice of fluid. For our expert audience, the discussion isn't really about if we give fluids, but which fluid. Is normal saline still the consensus default, or should we be perhaps pushing balanced crystalloids more given the broader critical care evidence?
Well, what's fascinating here is the evidence gap. Despite the critical nature of this intervention, there is still no consensus, no direct evidence from randomized controlled trials supporting the superiority of any specific fluid type, specifically for AKI prevention in rhabdomyolysis. The choice often rests on, well, theoretical risk reduction.
Let's delve into those theoretical risks then. Normal saline, 0.9% sodium chloride, carries that risk of inducing hyperchloremic metabolic acidosis, especially when you're giving massive volumes like we discussed.
Exactly. When you're pushing 10 to 15 liters of normal saline, you deliver a significant chloride load. That can induce a non-anion gap hyperchloremic metabolic acidosis. This is a concern because theoretically, an acidic environment in the tubules might actually exacerbate myoglobin cast formation, potentially compounding the AKI risk.
Right. Conversely, balanced crystalloids, like lactated ringers or plasmolite, have a lower chloride content, and they're closer to plasma osmolarity.
And that's the argument for balanced crystalloids. They might offer a modest benefit in reducing major adverse kidney events, as seen in large critical care trials like, say, the SMART trial, compared to normal saline. Therefore, balanced crystalloids may be preferred, especially in patients who are already acidotic or maybe at high risk of developing hyperchloremic acidosis. However, the caveat remains. This benefit is extrapolated from the general critically ill population. It's not proven definitively in rhabdomyolysis itself. The priority remains rapid volume replacement, regardless of the specific fluid.
Moving to the reality of actually administering such massive fluid volumes, aggressive fluid administration necessitates meticulous monitoring. What are the key clinical caveats we need to prepare for, especially when dealing with patients who have significant comorbidities?
You've hit the critical clinical trade-off there. While we must be aggressive, we also have to be individualized. Excessive fluid administration can rapidly lead to pulmonary edema and volume overload. This is particularly true in patients with underlying cardiac dysfunction. Think of that elderly patient with poorly controlled heart failure. In these challenging cases, where we really fear precipitating cardiac failure, maybe central venous pressure monitoring or even serial lung ultrasound assessments can be invaluable tools. They help titrate the volume while still maintaining that aggressive urine output target. So after the initial, say, 24 to 48 hours, when the CK levels hopefully begin their decline, how do we carefully step down the fluid titration strategy to avoid those iatrogenic complications?
Yeah, the rate must be judiciously reduced once the CK has peaked and is clearly trending down, or once we've maintained the target urine output for that 24-48 hour period. The titration should really be guided by the patient's daily weight, their overall fluid balance, and clinical signs of volume status. We need to ensure we don't swing from hypovolemia to severe volume overload. The clinician must transition from that high-flow flushing strategy to maintenance fluids, carefully monitoring for any signs of cardiac stress along the way.
Okay, that makes sense. Now let's tackle the high-stakes electrolyte shifts and the role of specific adjuncts. The potassium and calcium swings in rhabdo are rapid and potentially fatal.
Electrolyte surveillance is absolutely paramount. We need frequent monitoring, often every 4 to 6 hours, of potassium, calcium, phosphate, and magnesium. Given the risk of fatal arrhythmia, continuous cardiac monitoring is pretty much mandatory in severe cases or those with rapidly rising potassium.
Let's address the most immediate threat, hyperkalemia. For our audience of hospital physicians, we need to go beyond just saying standard protocols. Let's discuss the nuances of emergent treatment.
Hyperkalemia is definitely the most urgent, life-threatening complication. For immediate cardiac membrane stabilization, which is always step one if EKG changes are present, we use calcium. In the emergency setting, especially if you only have peripheral access, 10 milliliters of 10% calcium gluconate is generally preferred over calcium chloride. That's mainly due to the significantly lower risk of tissue necrosis if it extravasates. Although it's worth noting, calcium chloride delivers 3 times the elemental calcium per dose and might be used if you have secure central access.
Right. Safety first with peripherals, and then following stabilization, we have to rapidly shift potassium back intracellularly.
Correct. Shifting agents like insulin and glucose, for example, 10 units of regular insulin with 50 milliliters of 50% dextrose must be administered immediately. Beta agonists, like nebulized albuterol, are excellent adjunctive measures as well, especially in the setting of severe hyperkalemia. And renal replacement therapy is the ultimate safety net here. It's clearly indicated for refractory hyperkalemia that just fails to respond to maximal medical management.
Okay. Conversely, early hypocalcemia is common, but routine correction is strongly discouraged. We need to clearly explain the underlying physiology to our colleagues. Why the restraint? What's going on there?
Yeah, the early hypocalcemia happens because the large amounts of phosphate released from the damaged muscle bind with circulating calcium. This leads to precipitation of calcium phosphate into the injured muscle tissue itself. The restraint is crucial because as the kidneys recover and start clearing that excess phosphate, the calcium levels usually normalize spontaneously. Aggressive correction up front risks precipitating rebound hypercalcemia later on during the recovery phase, which can actually be quite difficult to manage and potentially contributes to things like heterotopic calcification.
So therefore, we reserve calcium correction only for patients who are actually symptomatic from the low calcium.
Precisely. Symptomatic hypocalcemia manifested by things like tetany, seizures, or perhaps QTc prolongation leading to arrhythmias. That's really the only indication for intravenous calcium administration in this specific context.
And what about hyperphosphatemia? Does that also require aggressive correction early on?
Hyperphosphatemia, while it's concerning, should generally be treated conservatively. Maybe use phosphate binders if it's severe. We reserve aggressive correction for symptomatic cases because, again, rapidly reducing phosphate can inadvertently worsen that already existing hypocalcemia, increasing the risk of cardiac and neuromuscular complications. Oh, and magnesium must also be monitored and corrected, especially in high-risk patients like those with chronic alcohol use, as hypomagnesemia can definitely exacerbate cardiac instability.
Good reminder about magnesium. Now for the classic controversy, the role of adjuncts like sodium bicarbonate and mannitol. We often discuss the theoretical benefits in academic settings, but what is the hard evidence supporting their routine use alongside aggressive fluids?
Yeah, the theoretical rationale is compelling, right? Urine alkalinization aims to increase myoglobin solubility and theoretically reduce its nephrotoxicity. Mannitol theoretically acts as an osmotic diuretic and may be a free radical scavenger.
But the clinical reality is that the evidence just isn't really there, and these interventions carry their own risks too.
Absolutely. We must emphasize the reality check here. Routine use of sodium bicarbonate, mannitol, or loop diuretics is not supported by strong clinical evidence or high-quality randomized controlled trials demonstrating superiority over aggressive intravenous fluids alone for preventing AKI.
So we reserve them for very specific rescue indications, rather than just using them as a blanket approach across the board for all rhabdo patients.
Precisely. Sodium bicarbonate should be reserved only for the correction of significant systemic acidosis, where the acidemia itself, say a pH pH less than 7.2 is detrimental to cardiac function and systemic hemodynamics. It should not be utilized simply to achieve some arbitrary urinary pH goal, especially given the risks of volume overload and potentially exacerbating that hypercalcemia. And mannitol should only really be considered if urine output remains stubbornly inadequate like oliguria persists, despite having achieved aggressive and adequate fluid administration. Fluid volume is the priority, always.
Okay, that clarifies the adjuncts. With the management plan solidified, let's look at the serious complications we must anticipate and the ultimate interventions, including renal replacement therapy, when medical management fails.
The most common and serious complication is, of course, AKI. We've talked a lot about that. But for our colleagues, active surveillance for compartment syndrome is absolutely crucial, especially in patients post-trauma or those who have had prolonged immobilization while in the hospital. This demands repeated clinical assessment of the extremities, looking for pain out of proportion, tenseness, paresthesias, and if suspicion is high, prompt surgical consultation for urgent fasciotomy is needed to prevent irreversible neurovascular and muscle damage.
And we must always remember that rare but potentially catastrophic coagulation complication too.
Right, disseminated intravascular coagulation, or DIC. While it is rare, it is severe. It results from the massive release of procoagulant substances from the large burden of damaged muscle. It requires aggressive supportive care, managing the bleeding and thrombosis.
When do we cross that line from intensive medical management to actually requiring RRT or dialysis? What are the hard indications for initiating dialysis in the setting of rhabdomyolysis-induced AKI?
Dialysis is reserved for the standard life-threatening complications that are refractory to our maximal medical therapy. The indications are pretty much the standard AKI criteria: refractory severe hyperkalemia, refractory severe metabolic acidosis, or refractory severe volume overload leading to pulmonary edema. The classic AEIOU indications, essentially.
We must be absolutely clear, though, RRT is not a treatment for the high CK or the myoglobin itself, correct?
That distinction is paramount for our colleagues. RRT is not indicated solely for highly elevated CK or myoglobin levels. We initiate it to manage the systemic metabolic consequences of kidney failure, not primarily to clear the muscle byproducts.
However, for our expert audience, there is some emerging data regarding techniques aimed specifically at myoglobin clearance. Can you speak briefly to the use of specialized filters in extreme cases?
Yes, this is definitely an area of ongoing research. In the most severe cases where myoglobin levels are extremely high, maybe greater than 10,000 nanograms per milliliter, and traditional RRT is already required for other reasons. Some centers utilize hemoadsorption techniques or specialized high cutoff or HCO dialysis filters. These filters are designed with larger pore sizes intended to remove larger molecules like myoglobin. Recent consensus recommendations do support considering this as an adjunct therapy in those select cases, but it is certainly not standard first-line RRT. Its definitive impact on actual clinical outcomes remains subject to further research.
Interesting, something to keep an eye on. Finally, let's wrap up with the monitoring aspects and the long-term prognosis for these patients.
Serial lab monitoring is vital, particularly charting the daily or maybe even twice-daily trend of CK, renal function, and electrolytes. You continue that until the CK is clearly declining towards baseline. Assuming timely and aggressive intervention, the prognosis is generally favorable. However, outcomes are very strongly linked to the prevention and severity of AKI. If we manage to prevent severe AKI, the long-term prognosis for renal function is typically quite good.
And what about the longer view thinking about secondary prevention and follow-up care?
Yeah, long-term follow-up must address both physical sequelae like persistent weakness or pain and potential psychological sequelae, as recovery can sometimes be prolonged and traumatic. Crucially, for any patient presenting with recurrent or unexplained rhabdomyolysis, an aggressive workup, potentially including genetic testing, is strongly recommended. We need to identify any underlying neuromuscular or metabolic disorders that might predispose them to this condition. Finding the root cause is key to preventing future, potentially fatal episodes.
Okay, great points. Let's unpack this entire deep dive into rhabdomyolysis, into the immediate, actionable takeaways for our colleagues managing these patients in the first critical 24 hours. The key actions seem clear and evidence-based.
First, maintain a high index of suspicion. Remember the non-specific presentation, especially in high-risk patients, those with immobilization, polypharmacy, sepsis. Consider using tools like the McMahon score for early risk stratification.
Second, diagnosis requires that CK level greater than 5 times the upper limit of normal. That should trigger immediate concern and mandatory action.
Third, and probably most critical, Initiate aggressive intravenous fluid resuscitation. It's the absolute cornerstone of care, and ensure it's initiated within that critical 6-hour window of muscle injury.
Fourth, target a high urine output of 300 milliliters per hour for at least 24 hours. Be prepared to adjust the massive fluid input based on the patient's cardiac and pulmonary status, monitoring closely.
Fifth, strict monitoring and emergent treatment of hyperkalemia are absolutely non-negotiable. Utilize calcium gluconate for immediate cardiac stabilization if peripheral access is the only option, followed swiftly by shifting agents like insulin glucose and maybe albuterol.
And finally, number 6, avoid the routine use of adjuncts like bicarbonate and mannitol unless very specific indications, severe systemic acidosis or persistent oliguria despite adequate volume are unequivocally met. Fluid volume is the undisputed priority.
You know, this does raise an important question, though, and it highlights a critical gap in our evidence base that you, the hospital physician, will inevitably encounter. While early volume expansion is the undisputed foundation of treatment, the precise choice of fluid, whether normal saline or balanced crystalloids, actually provides a superior clinical benefit specifically for AKI prevention in rhabdomyolysis. That remains an area where high-quality, randomized controlled trials are still desperately needed. We rely heavily on critical care generalizations right now, and future data could potentially refine our protocols quite significantly, particularly for those complex patients with coexisting cardiorenal syndromes.
It really seems like the core management principles are solid, but the nuanced refinement of treatment, especially fluid choice, awaits more specific, dedicated data. That uncertainty is where clinical judgment and individualized patient care truly matter day to day.
Absolutely. It remains a critical area for future research that could genuinely optimize patient outcomes down the line.
Thank you for joining us for this in-depth exploration of rhabdomyolysis management.